Welcome back to the deep dive. Today, we are taking on a topic that is, perhaps paradoxically, one of the most enigmatic and enduring constructs in personality pathology.
And yet at the same time, it's one of the most invisible.
Exactly. We are diving into schizoid personality disorder, or SEPD. We're going to try and map out the anatomy of radical isolation.
It's a really fascinating area of study because it forces you to, to re-examine what we even mean by connection.
Right.
When most people think about personality disorders, their minds often jump immediately to the more dramatic presentation.
Oh, yeah, the cluster B disorders.
Exactly. Borderline, narcissistic, antisocial.
Mm.
The ones that are very visible, very volatile. But SEPD, it sits quietly in cluster A. That's the odd or eccentric cluster.
And it's defined by something completely different. A silent, persistent, and in a way, a successful withdrawal from the world.
That's the key. Successful withdrawal.
And that distinction is crucial. The sources you provided, and you gave us a really comprehensive clinical report, they challenge us to look past that surface silence, past the apparent lack of conflict. So our mission today is to really try and unpack the profound, protective internal complexity that defines this kind of isolation. We want to understand the architecture of someone who just fundamentally chooses to live outside the standard network of human connection.
Right. So to frame it precisely, the DSM-5-TR, it defined SEPD as a pervasive pattern of detachment from social relationships.
Okay, detachment.
And coupled with that, a really restricted range of expression of emotions in interpersonal settings.
And this isn't just a phase, right?
No, absolutely not. That's crucial. This isn't a temporary state. It's a stable, chronic pattern that is, clearly present by early adulthood. It's the way the personality is organized.
And the history of the term itself is important, I think, because it helps clarify what we're actually focusing on here.
It absolutely does. The term schizoid came about from observing traits that looked a lot like the negative symptoms of schizophrenia.
Okay, so things like withdrawal.
Withdrawal, emotional flatness, that lack of motivation we call avolition, and anhedonia, the inability to experience pleasure.
But the critical point, and the sources really stress this, is the complete absence of the positive symptoms.
Yes. There are no delusions, no hallucinations. SEPD individuals are reality-based. They're rational. Their thinking is sound.
So while there's a strong genetic link to the schizophrenia spectrum, which suggests a kind of shared vulnerability.
Right, especially around those negative symptoms.
SEPD is still its own thing, a distinct clinical entity. It's a stable, lifelong way of being.
In this chronic, stable nature, it brings up this twofold challenge with the disorder. First, as we'll get into later, there's the diagnostic challenge.
Distinguishing it from things that can look very similar on the surface.
Exactly, like autism spectrum disorder or avoidant personality disorder. But second, and maybe even more formidable, is the challenge of treatment.
Because if the core of the disorder is detachment.
And that detachment is a deeply successful defense, a sort of a fortress that guarantees their survival. Why would the patient ever want to give it up?
It sounds like the clinician's first job is just to introduce a little doubt into what seems like the patient's perfect solution to the problem of life.
That's a great way to put it.
We have to get past the observable symptoms and really understand why this radical isolation had to be built in the first place.
Okay, so let's start with that overt presentation, the external data points that are used for diagnosis. The report you sent detailed the 7 pillars of detachment.
Right, and you need at least 4 of the 7 for a diagnosis.
What's so striking to me is how these criteria focus entirely on what's missing, what's avoided. It feels like a diagnosis by deficit.
It is. That's the very hallmark of a negative symptom presentation. It's all about what's not there, deficits in behavior, in capacity. It's not about excesses or volatility.
So the first 2 criteria, they really set the stage. Criterion 1. Lacking a desire for intimacy, including even being part of a family. And criterion 2, almost always choosing solitary activities.
This is where that first big clinical distinction has to be made.
Absolutely. You must immediately differentiate this from fear. This is not the avoidant individual who is, desperately lonely and just consumed by the fear of rejection.
They want connection, but are terrified of it.
Right. The schizoid individual, on the other hand, exhibits a fundamental lack of appetite for human bonding. It's like the drive is missing, or it has been so pathologically suppressed that it's just not a factor.
So they aren't suffering from loneliness in the way you or I might understand it. They're just indifferent to connection.
Indifference is a good word. Their primary motivator is safety. For them, isolation equals survival, and connection equals danger. So the drive for intimacy is either completely absent or it's so quiet it just can't override that deep, primal need for self-preservation.
And that directly explains their choice of activities. The sources note that their solitary preference is for genuine aloneness, not just, quiet time to recharge like an introvert.
It's not about recharging. It's about guaranteeing isolation.
Right.
You look at the professional profiles cited in the report. Night shifts, where interaction is almost zero. Archival research, where your primary relationship is with, documents and dust.
Long-haul trucking was another one, certain kinds of programming.
All things where you can engage with ideas, with systems, with objects, anything that doesn't demand that messy, unpredictable, emotional back and forth that comes with people.
They're actively building a life to minimize the chances of human contact.
Precisely. And that flows right into criterion 3, which is sexual disinterest. And again, the nuance here is really key.
It's specifically about the relational side of sex.
Exactly. The drive for deep, intimate sexual connection is often absent or just heavily shut down because it represents the ultimate intrusion.
The ultimate invasion of the self, of the body.
Yes. And the material was very clear that this drive often gets rerouted. It might be replaced by autoerotic behavior that's fueled by fantasy.
A safe internal experience.
Or sometimes by very mechanical, transactional, physical acts that have no intimacy attached. The critical element is that the physical act has to remain totally separate from any real emotional connection. That keeps the defensive wall up.
Okay, then we have criterion 4, anhedonia. This global dampening of the ability to feel joy. They take pleasure in few, if any, activities.
This one is it's devastating when you really think about it. And we have to remember, this anhedonia is a stable trait. It's part of the personality structure.
So it's not like in depression, where you lose pleasure in things you used to enjoy.
No, it's not a temporary reactive state change. For the schizoid individual, that capacity for intense joy might have never fully developed in the first place, or more likely, it's been pathologically flattened as part of the whole emotional defense system. It's like a permanent low ceiling on what you can feel.
Living life in emotional grayscale, that's a powerful image.
It is.
Okay, so moving on. Criterion 5 is a lack of close friends or confidants, other than maybe some obligatory first-degree relatives.
And the key word there is confidant. The defining feature is the total absence of a person they truly open up to.
So their inner world is sealed.
Completely. The rich fantasy life we're going to talk about later, it is never, ever shared. They might have a sibling or a parent they have to interact with, but even those relationships are often, transactional, superficial, maintained out of sheer obligation, never reaching any genuine emotional depth. The fortress is sealed tight.
And if the inner world is sealed off, it makes total sense that they'd be impervious to external feedback. That's criterion 6. The sources describe this striking indifference to social reinforcement.
This is one of the most frustrating things for family members or colleagues to deal with. You can shower them with compliments, praise their work, and you get nothing. No visible, lasting change in mood.
And on the flip side, you can criticize them and nothing.
No visible defensiveness, no shame.
Yeah.
It doesn't seem to land.
How is that even possible for a person to be so unaffected?
Well, it speaks directly to that defense mechanism we'll keep coming back to. The false self.
The mask.
Exactly. Since they've locked their authentic self away deep inside, any feedback, positive or negative, it's just directed at the mask, at the functional role they're playing. They feel subjectively detached from it. So the feedback just misses the target. It's like criticizing a performance by a robot. The actual person inside isn't even listening.
Which leads us to the final one, criterion 7. The overt presentation of emotional coldness, detachment, or that flattened effect.
Right. This is the visual confirmation of everything we've been talking about. The internal shutdown made visible, the person appears aloof, maybe a little robotic, maybe just kind of in a fog.
And they don't do the normal social things like smiling back at someone.
Rarely. They just don't reciprocate those social gestures. Their voice is often monotone. And this aloofness, it serves a function. It's a social barrier. It naturally pushes other people away, which maintains that defensive distance without them even having to try.
Okay, let's talk about how visible this disorder really is. You mentioned it's pretty uncommon in clinical settings. What do the numbers say about its actual prevalence, and why is it so often missed?
The general population estimates are, they're pretty broad. They range from just under 1% to nearly 5%.
That's a big range.
It is. And the reason for that low clinical visibility is because their lifestyle is what we call egosyntonic.
Meaning it feels normal and right to them.
Exactly. Their detachment feels natural, comfortable. They rarely seek help on their own because, in their mind, they don't have a problem society does. They only tend to show up in a clinic when they're forced to by some external crisis, or when a co-occurring condition, like a really severe depression, finally breaks through their defenses.
And the sources noted it's diagnosed a bit more often in males.
Yes, and the male presentation often includes more severe social impairment. That's pretty consistent across a lot of personality pathology literature. But here's the statistic from the report that really just struck. It forces you to reevaluate the consequences of this so-called quiet disorder.
The high-risk population data.
The prevalence rates of up to 14% in some samples of the chronically homeless population.
14%, that's a massive jump from the general population rate. Why is this specific personality structure so strongly linked with that kind of severe socioeconomic decline?
Well, clinicians have a term for it, downward drift.
Okay.
Think about what our society demands of us to function. Demands cooperation, negotiation, emotional reciprocity, networking.
All the things they can't or won't do.
Precisely. The ability to tolerate sustained intimate relationships, whether it's with family, at work, or romantically. If you are fundamentally detached, if you lack that appetite for human bonding, if you're incapable of emotional sharing, and you're indifferent to social approval, you're profoundly ill-equipped to maintain the very networks required for a stable life.
So the inability to connect becomes this kind of slow-motion catastrophe.
That's a perfect way to describe it. Over time, that inability to navigate relationship friction or to secure a social safety net, it just leads to functional decline. They isolate themselves from colleagues, they lose jobs that require collaboration, and they have no support system to help them manage a financial or health crisis.
The detachment itself pushes them to the margins.
It does. It pushes them toward the very edges of society, often resulting in homelessness. And it just shows that while SCPD is quiet, its consequences can be incredibly severe and life-altering because, at the end of the day, that level of detachment is not truly sustainable in a social world.
That progression from the quiet loner to someone in a crisis of downward drift, it really shows that the observable symptoms are only telling half the story. The DSM criteria, they just describe the overt shell, but the clinical report you gave us repeatedly stresses that the deeper reality is this complex, defensive, internal adaptation. So we need to go inside the fortress now.
This is where the modern understanding of SCPD really offers its most crucial insights. We have to distinguish between the overt and the covert presentation.
Okay.
The overt schizoid is the classic loner we picture. Monotone, visibly withdrawn, living alone in an apartment or a cabin. They're pretty easy to spot.
But the covert schizoid, that's the person who is often missed entirely, even by professionals, until some major crisis happens.
The covert schizoid presents a remarkably successful false self. This is someone who might be married, have kids, hold down a respectable job as a manager or a technician. They pay their mortgage. On the surface, they look fine.
But their sociability is all a performance.
It's purely a performance. A mask they wear to deflect scrutiny, to satisfy social obligations, and just to avoid being seen as too weird.
And the sources say that subjectively, on the inside, they feel completely detached from all of it. They're just acting out a life.
Yes, they describe themselves as being like a robot. Or, in one of the more poignant metaphors from the literature, like an anthropologist observing humanity from behind a thick glass wall. They're participating mechanically, but they're making sure that their authentic, true self remains completely isolated and safe inside, untouched.
And this hidden detachment, as we touched on, has massive clinical implications. If they appear to be high-functioning, they just get misdiagnosed as, introverted or maybe just a bit reserved.
Oh, all the time. It often takes a really severe crisis, a partner threatening divorce because they finally realize their spouse has been emotionally absent for 20 years.
Or a job loss that forces them to actually try and ask for social support.
Exactly. Something that cracks the mask. And when it cracks, the emptiness and the profound lack of connection underneath is suddenly exposed.
And this hidden true self, it finds refuge in what is arguably the most defining, and this is a non-DSM feature, of the disorder, the elaborate egocentric fantasy life.
This is the critical component. The sources describe this fantasy life not as simple daydreaming or escapism. It is a substitute for reality. It is the schizoid individual's highly controlled internal ecosystem.
Okay, how does it function as a substitute? What does that really mean?
Because it's entirely self-controlled. The people, the power dynamics, the relationships, the conflicts, all the objects of fantasy pose absolutely no threat.
No threat of rejection or engulfment.
None. It is the one place where they can safely experience and manipulate all the intense, volatile emotions they've exiled from their real life. Things like aggression, deep love, power, intimacy,
So it can be a hero, a lover, a warrior.
anything they want, an emperor, all without ever needing another actual person to validate or, complicate the experience.
The content of these fantasies isn't just simple wish fulfillment. We're talking about extremely complex narratives, detailed internal worlds, avatars, idealized relationships that are totally self-contained.
Yes, patients can spend hours, days just engaging in these internal dramas.
Yeah.
It is an entire parallel existence that is, for them, far superior to the messy, threatening external world.
And that leads to the cost.
A massive cost. This reliance on fantasy fundamentally reinforces the detachment. I mean, if your internal world is rich, controlled, and perfectly tailored to give you all the emotional gratification you seek, why would you ever bother navigating the messy, unpredictable, and potentially catastrophic nature of actual human relationships?
The fantasy world becomes a huge disincentive to engage with reality.
A constant one. It's always there, always safer, always better.
And that connects directly to this idea of the empty core and the emotional paradox they live with. The clinical material states that the emotional coldness we see on the outside is actually a defense against a terrifying underlying sense of inner emptiness, of deadness.
Psychodynamic theory suggests that the individual feels their authentic self is, inherently inadequate, maybe dangerous, or just doomed. So to protect it, they sequester it. They hide it deep within the psyche, away from the world and even from themselves.
And when you exile the true self,
What's left in its place? An empty core. A vacuum where the personality should be connecting and reacting. And this emptiness is profoundly uncomfortable, and it just drives the need for even more defensive isolation.
and while they might have profound difficulty identifying or expressing their own feelings, a state called alexithymia, this isn't necessarily because they don't have the capacity to feel, is it?
No, and that is the beautiful, heartbreaking paradox of this whole thing. The stereotype is that they're cold because they can't feel, but the underlying reality is often that they are cold because they must feel nothing in order to survive.
They're actually overly sensitive?
They often possess a latent, extreme sensitivity. They can be what the literature calls hyperpermeable to other people's emotions.
What does that hyperpermeability actually look like in practice? What does that feel like?
It means that the massive, unfiltered flood of feeling from the outside world is experienced as overwhelming. It's chaotic, it's intrusive. Imagine standing in a crowd and feeling the emotional static of every single person around you.
Yeah.
Their anxieties, their needs, their anger, all just flooding your system without any boundaries.
That sounds terrifying.
It would be.
Yeah.
Because the schizoid individual lacks that usual psychological filter, they find other people's emotional expression to be profoundly demanding and threatening. And this necessitates a total protective shutdown of their own affect. They build that thick glass wall, not because they lack feeling, but because they are terrified of being emotionally drowned by the feelings of others.
So the emotional coldness is an active protective shield. It's a defense against being annihilated by external emotional demands.
Exactly. It's a defensive adaptation to prevent sensory and emotional overload. And this is why their withdrawal is so often successful and so persistent. It solves that immediate, terrifying problem of feeling overwhelmed.
Okay, so let's unpack this intense sensitivity and the withdrawal that follows it by tracing its origins. The sources you sent paint a clear, multifactorial picture, starting with genetics.
The heritability component is remarkably strong. Twin studies estimate it at around 27 to 30%. So while environmental factors clearly shape the behavior, there's an innate biological predisposition toward this kind of personality organization.
And the connection to schizophrenia supports that genetic carrier state hypothesis.
Which is really key to understanding the biology here. Schizoid personality disorder is significantly more common in the first-degree relatives of individuals who are diagnosed with schizophrenia.
Right.
The hypothesis suggests they carry the genetic risk factors specifically for the negative symptoms.
The withdrawal, the anhedonia.
Exactly. The avolition, the flattened effect. But, and this is the crucial part, they do not inherit the risk factors for the structural brain abnormalities or the positive symptoms that lead to a full-blown psychosis. They get the deficits in motivation and reward, but not the tendency to break with reality.
And speaking of motivation and reward, the report characterized their neurobiological temperament with two key behavioral traits: low reward dependence and high harm avoidance.
That pairing is just. It's so descriptive of the life choices a schizoid individual makes. Let's look at low reward dependence first. It means they are fundamentally indifferent to social approval, to praise, to status, to validation from others.
So how does that play out day to day?
Well, they're not going to be the ones chasing a promotion for the ego boost. They're not engaging in office gossip or political maneuvering. They don't rely on holidays or parties for pleasure. Since social interaction isn't chemically reinforcing for them, they don't get that rewarding dopamine hit from connection that most people do. They simply don't seek it out. Socializing is all effort with a very low return on investment,
And you pair that with high harm avoidance.
which is the behavioral preference for passive withdrawal. They pull back from confrontation, from novelty, from engagement. They avoid any situation that is emotionally risky or unpredictable.
So that combination, no real incentive to engage, plus a strong aversion to risk it points to.
A potential dopaminergic hypofunction in the brain's reward centers. It basically means that, for their brain chemistry, isolation is inherently safer and less frustrating than trying to connect.
So if that's the biological backdrop, then the environment comes in and sculpts the expression of that vulnerability. And here we get into early attachment failure and the insights from object relations theory.
Yes. The problem, in this view, starts in the earliest interactions, where the primary caregiver fails to provide what's called good enough emotional attunement.
And this failure shows up in two really damaging ways, according to the material. The caregiver is seen as either intrusive or neglectful.
Right. An intrusive caregiver might overwhelm the child. They might smother them or treat them like an extension of their own needs with no respect for the child's separateness.
And that forces the child to pull back.
Radically. They learn that the only way to establish any sense of self, any boundaries, is to just shut down communication and retreat into an internal world.
And the neglectful caregiver.
That leads to withdrawal out of sheer despair. The child learns that crying out for connection or for validation gets no response. It's like shouting into a void. And that leads to a profound resignation.
This type of developmental damage is described as cumulative trauma, which is a really important distinction from acute, one-time trauma.
Yes, cumulative trauma is the death by 1,000 cuts. It's the consistent chronic trauma of emotional misattunement. The child lives in an environment where their core emotional needs, for comfort, for connection, for validation, are consistently ignored or invalidated or maybe even subtly mocked.
And they learn a core pathological lesson from this.
They learn that needing is painful and dangerous.
And the only way to survive that realization is to become pathologically self-sufficient.
They have to sever the connection to their own emotional needs. They retreat because they have learned, over thousands of interactions, that connection hurts far more than isolation ever could.
And this retreat starts early.
Very early. Retrospective studies consistently show that these adults were often hypersensitive, solitary, sometimes odd children who were just easy targets for teasing or bullying at school, which then, of course, just reinforces their deeply held belief that the external world is hostile and unpredictable.
And this external validation of their fear pushes them even further inside, into that controlled internal world, which brings us to the core psychodynamic mechanism, the schizoid compromise.
This comes from Schopenhauer and Freud's concept, often called the porcupine dilemma.
Right.
The schizoid individual faces this devastating internal conflict that exists deep beneath the surface. You have the unconscious, universal human craving for intimacy.
Which everyone has.
Everyone has it. But it conflicts with their conscious, pervasive fear of that same intimacy. For them, intimacy is experienced not as warmth or comfort, but as annihilation, as the painful engulfment of their already fragile, hidden identity.
So they're constantly negotiating this distance between themselves and other people. If they get too close, they risk being pricked or suffocated.
But if they get too far away, they risk freezing from that emotional isolation.
It's an impossible situation.
It's an intolerable tension. And the compromise, the schizoid compromise, is the solution they find to manage it. They keep others at a precisely calculated safe distance, just close enough to observe and analyze humanity so they can function, but far enough away that they can't be touched, emotionally or physically.
And this explains that pattern you see in their relationships of approaching and then suddenly retreating.
Yes, that characteristic in and out dance, you see it in their relationships, and as we'll discuss, you see it in therapy itself. The patient will cautiously approach connection, and then, often for no apparent reason, they'll suddenly and completely retreat back into the fortress.
Okay, this internal complexity, this strategic retreat, it must make diagnosis incredibly challenging, which is why we have to spend some time on differential diagnosis. For you listening and trying to get clarity, the classic point of confusion is with avoidant personality disorder, or AVPD.
This is the single most important distinction to grasp. It all comes down to desire versus fear. We have to contrast active detachment with passive detachment.
Okay, so the AVPD individual is in a state of active detachment. They desperately want a relationship, they want to be loved, they want friends.
But they are paralyzed by the terror of rejection, of embarrassment, of shame.
So for them, isolation is painful. It's what we call ego dystonic.
Yes, it feels wrong, unnatural, deeply uncomfortable. They are hypersensitive to criticism. They're constantly scanning faces for any sign of disapproval. They feel intensely lonely, and that loneliness is a form of suffering they desperately wish they could escape.
Now contrast that with the schizoid PD individual. Their state is passive detachment.
Right. They do not appear to suffer from loneliness. They are indifferent to social judgment or criticism because, as we said, that feedback is just hitting the mask, not the true self.
So for them, isolation is comfortable. It's egocentric.
It is. It feels natural, correct, and self-preserving. If you ask a schizoid person if they're lonely, they might honestly look at you, confused, and say no. If you ask an avoidant person if they are lonely, they will say yes, immediately and painfully. That difference is the gold standard for clinical differentiation.
But the clinical report did acknowledge that there's a significant gray area where this distinction can get kind of blurry.
Yes, and this is where, good clinical intuition is really needed. Some individuals may start life organized more along an avoidant structure. They feel that acute pain of longing and fear. But over decades of repeated social failures and unfulfilled needs, they can develop these secondary schizoid defenses. They essentially numb the pain until they become genuinely indifferent.
So they turn their painful ego-dystonic isolation into a protective ego-syntonic one.
Exactly. They start out seeking connection, and they end up avoiding the very need to seek it at all. It's a tragic adaptation.
The second, and I'd argue more complex differential diagnosis is with autism spectrum disorder, ASD, especially in high-functioning adults who may have gone undiagnosed for decades.
The external presentation, the withdrawal, the restricted affect is often highly, highly similar. This leads to a massive amount of diagnostic overlap and confusion.
But the core difference lies in the source of the social deficit. It's motivation versus capacity.
Let's break that down. In SEPD, the primary deficit is motivational. It's a psychological defense. They lack the desire for connection because they find it threatening. They have the capability to understand social rules, but they actively choose to ignore them.
Whereas in ASD, the primary deficit is capacity.
It's neurodevelopmental. They lack the innate intuition or the skill for social connection. They struggle to instinctively read social cues, which often leads to high social anxiety as a result of these repeated, confusing social failures.
So they're often trying really hard to connect, but the machinery is faulty.
Precisely. The schizoid isn't trying because they don't want to. It's a world of difference in the internal experience.
And their internal worlds are fundamentally different too, right? The schizoid fantasy life is rich, it's narrative, it's highly interpersonal. It serves as a substitute social world that they control.
Yes. Whereas in ASD, the intense internal focus often centers on systems, objects, or special interests. Trains, mathematics, history, complex mechanics. It's less focused on creating interpersonal surrogates.
And you also look for core features of ASD that SCPD just doesn't have.
Right. Things like sensory sensitivities, an aversion to loud noises or bright lights, and repetitive motor behaviors or restricted routines, what's often called stimming. These are very rarely primary features of SCPD.
That leads to this powerful distinction the source material made between mind blindness and mind blocking. That really clarified the core difference for me.
It's a fantastic way to frame it. If ASD is characterized by mind blindness, that inherent difficulty in intuiting and understanding what's going on in other people's minds.
Then SCPD is characterized by mind blocking.
The schizoid can understand social cues. They're typically intelligent, analytical observers of the human condition. But they actively choose to block those cues out, to ignore them, or to find them irrelevant to their internal goal of safety and self-preservation. It is a willful, defensive disengagement from social reality.
Finally, we need to quickly touch on the distinction from the other cluster A member, schizotypal personality disorder, or STPD.
The easiest way to remember this one is the distinction between invisible and weird.
Okay.
Schizotypal PD involves active cognitive distortions, things like magical thinking, superstition, transient paranoia, ideas of reference.
Believing that random coincidences are secret messages meant for them.
Exactly. And often they have a very eccentric, unkempt appearance. They are noticeable. They're actively weird in a way that often causes other people to pull away from them.
Whereas the SCPD individual is just invisible.
Completely. They only display those negative symptoms we talked about. Their thinking is rational, it's logical, it's entirely reality-based, even if it is profoundly cold. They're the ones who they disappear into the background.
Understanding the architecture of this isolation is one thing, but we need to talk about the practical reality of living with this. What happens when this carefully constructed defense starts to fail, and what does the clinical world have to offer?
As we've established, patients rarely seek help for the detachment itself. It's not the problem from their perspective. They come in because of the associated conditions that finally break through the defenses.
And depression is the most common one, occurring in up to 50% of cases.
It is.
But I want to come back to this point. If the fantasy life is so rich, so controlled, so egocentric, and it provides all the emotional input they need, why does depression still hit half of these patients?
That is the critical tension we have to address, because this isn't sadness or grief in the way we normally think about it. The sources describe it as an empty depression, or as schizoid depression. It's defined less by acute sadness or low mood, and more by a profound, pervasive sense of futility and meaninglessness.
Because if they've successfully detached themselves from the human world, which is the primary source of existential meaning and value for our species, they eventually have to face that internal emptiness.
That's it, exactly. When the true self is exiled and protected, it's also starved of any nourishment from genuine connection, and that leads to a profound vacuum at the core. The fantasy world is a powerful coping tool, but it cannot ultimately substitute for true existential purpose, so that chronic low-grade depression is the consequence of succeeding too well at isolation.
And anxiety can also be a major issue, but it's not typically social anxiety, which is AVPD territory.
No, they're generally indifferent to social judgment. Their anxiety emerges when their meticulously constructed ecological niche of isolation is threatened by some kind of external intrusion.
Like what?
The material cited cases of generalized anxiety disorder, GAD, developing when, for example, a successful remote worker is suddenly forced to go back into a highly social office environment. That disruption of their safe, controlled space is experienced as catastrophic. It's a deep threat to their survival.
We should also briefly mention the potential for brief psychotic episodes, which can be confusing when you're trying to make a diagnosis.
Yes. Under conditions of extreme prolonged stress or loss, often related to the crumbling of their niche, the schizoid's ability to maintain their psychological defenses can just temporarily fail.
And they have a break with reality.
A brief one. This can lead to transient psychotic episodes that might only last minutes to hours. They quickly return to their baseline. And that transient nature is a key feature that differentiates it from the chronic, sustained psychosis you see in schizophrenia.
Let's pivot now to therapeutic interventions. The report is very, very candid about the immense difficulty in just establishing a therapeutic alliance.
It's the first and biggest hurdle. The patient's fear of intrusion and their profound lack of motivation to change are huge barriers.
So the goal has to be modest.
Modest but meaningful. The goal is not cure. You're not trying to transform a schizoid into an extrovert. The goal is fostering connection. The therapist aims to help the patient tolerate one safe relationship, the therapeutic one, as a kind of functional, secure bridge to the outside world.
Can minimize their reliance on that internal fortress.
Exactly.
Psychodynamic psychotherapy is considered the treatment of choice for making any kind of structural change. But how do you even start that process with someone who uses silence as their primary defense?
The therapist has to establish a consistent, non-intrusive holding environment. This means absolute consistency, respecting the patient's distance. In the session, silence isn't seen as resistance or rudeness. It's a form of communication.
A boundary-setting mechanism.
Yes. So the therapist has to be incredibly patient. You have to wait, and your job is to gently, slowly try to make contact with that sequestered true self.
Probing beneath the mask.
You probe beneath that mechanical, false self. A key part of the process is validating the patient's rich internal experience, their elaborate fantasy life. You have to signal that it's interesting, it's valuable, and crucially, that it's safe to share.
And only once that safety is established
can you begin to use the relationship itself as the learning tool. You start to interpret the schizoid compromise in real time.
For example, interpreting the very moment they withdraw in the session.
Yes. The therapist might analyze the here and now dynamic by saying something gentle, something non-accusatory like, "I noticed you pulled away and your voice became flat," right after I asked how you felt about your mother. Is that connection between feeling and defense something you're aware of?
You're helping them see that the withdrawal is a defense against anxiety, not just an inherent part of who they are.
It introduces the idea of choice. It reframes the whole experience.
Okay, on the more practical side, cognitive behavioral therapy, CBT, offers tools for immediate functional improvement, especially for those comorbid issues like depression.
CBT focuses heavily on identifying and challenging the patient's core schemas. SCPD patients often hold these rigid, permission-giving beliefs for their isolation.
Like what?
Things like, people are trouble and will always hurt you, or I am inherently better off alone because relationships are futile. CBT aims to systematically identify those beliefs and then test them in the real world.
Plus, social skills training and behavioral activation to get them out of that purely solitary confinement.
They need tools to function. Role-playing, assertiveness training, even scripting can help them navigate necessary social interactions, like dealing with a demanding boss or a family obligation, with less friction and less anxiety. And behavioral activation encourages them to expand their life beyond just solitary activities, to find non-relational sources of pleasure or mastery out in the real world.
And finally, what about group therapy? I mean, that sounds like the worst possible scenario for a schizoid individual.
It is extremely high risk. It carries a significant chance of immediate dropout if the group is too confrontational or too emotionally demanding.
But it can work.
If managed correctly, yes. The group can act as a social lab. The schizoid patient can observe other people expressing emotions, resolving conflict, and experiencing connection without the immediate pressure to participate or reciprocate. Over time, that can provide a vital resocialization experience, gently challenging their deeply held belief that they are fundamentally alien to the entire human race.
Okay, finally, let's look at the long-term prognosis. The sources describe SCPD as a chronic condition defined by stability, with really low rates of spontaneous remission. What determines the quality of their long-term functional outcome?
It hinges almost entirely on the individual's ability to find and maintain an ecological niche.
A safe space.
A safe space. If a schizoid individual can secure stable, solitary employment, a remote IT position, a technical writing role, night work, something that matches their intellectual capabilities, they can function quite well. They can maintain their independence and be financially solvent indefinitely. Their functionality is directly tied to the success of their isolation strategy.
But for those who fail to find that niche, the ones who experience that downward drift we talked about, they face severe risks.
And this risk just compounds significantly with aging. We have to consider the aging crisis. As their obligatory social network, the parents who manage the bills, the siblings who check in, as that network inevitably collapses through death or illness.
The aging schizoid is left completely alone.
Utterly isolated. And this loss of the last vestiges of human connection can precipitate a severe, meaninglessness-driven depression in later life, coupled with a total crisis of care, because they have built a life where there is no one to rely on.
We have dissected this internal fortress, we've understood its origins, we've analyzed the clinical response and acknowledged the immense challenges. This whole deep dive really reveals SCPD is a profound organization of personality around one central defensive axis: safety through total isolation.
It's the ultimate tragedy of the schizoid compromise, the universal human need for attachment. It never truly vanishes. But for the schizoid, attachment itself is experienced as an existential threat to the self, a threat of annihilation or engulfment that is just too terrifying to face. So they choose safety over intimacy, and that leads to a life that is quiet, controlled, but perpetually, exhaustingly defended.
So the goal of any intervention is just to help them tolerate a small amount of external risk.
So that their life isn't completely devoid of meaning. That's the hope.
So what does this all mean for you, our listener? We've seen how rich the schizoid's internal world is, how safe, how customized, how completely controllable it is. This fantasy life provides a highly effective alternative reality for emotional gratification without any of the pain of rejection.
And this raises the fundamental, provocative question that I think encapsulates the core therapeutic challenge of this entire disorder. If the internal world is so fully mastered and provides everything the individual needs without the risk of rejection or pain that the external world guarantees, is it ever truly possible to convince someone that the external world, with all its risks, its chaos, and its unpredictability, offers a better, more fulfilling form of life than the one they have already perfected within the safe confines of their own mind?
A profound thought to end on. It suggests the real fight isn't against a deficiency, but against a deeply entrenched and, in many ways, a very successful alternative reality. Thank you for guiding us through this complex and often invisible organization of personality.
My pleasure. It was a fascinating deep dive into a structure built for solitude.
And thank you for providing the comprehensive sources that allowed us to take this detailed look today. We'll be back next time with another investigation into the forces that shape our world.